Bom.
Professor Gabriel, boa noite.
How are you?
Nice.
So, to avoid any other delays, I'm going to start the presentations, and then we launch the lecture. So, just would like to thank everybody who is here tonight for our 5th class of our HPB 23 course on liver transplantation and HPB surgery as well. So this has been the 3rd edition of this Congress, and every time we try to bring all the most important authorities on the field, that it be in the country or even in Argentina, like Professor Gondolesi and people elsewhere. So we are very proud to have so many students. In this edition, we had almost 1,000 people enrolled for the course. So for tonight, presentation is going to be about liver transplantation, the standard technique, as well as the alternative techniques that we may sometimes require for some specific situations, such as portal thrombosis or even cable problems. So I have invited Professor Gabriel Gondolesi, who is the head of the HPB and Transplantation Center at Hospital Universitário Fundación Favaloro in Buenos Aires, Argentina. Pleasure to have you here, Professor Gondolesi. And as well, Dr. André Watanabe, who is the director of the team in Brasilia that perform liver transplantation in Brasilia, one of the most active liver transplantation centers in Brazil. Nice to have you here too. And my friend, Dr. Marcelo Bruno, who is also head of the service at Hospital Albert Einstein in São Paulo, as well, not only in transplantation, but also on digestive oncology and the HPB surgery. And for the tonight presentation, Professor Thiago Beduschi, who is Brazilian, and who is the head of the University of Florida Service of Transplantation. So thank you very much for all of you with us tonight, and I hope you're going to have a very nice discussion as a nice presentation. Thank you very much for your presence.
It's with me, João. Thank you so much for the invitation once more. It's always a pleasure to be here. It's a pleasure to receive students that you sent to us as well. I think it's a great cooperation to have them here. We have students from Marcelo as well. It's good to see you, Marcelo. Gabriel, friends of a long term. And Andrea, we don't know each other in person, but I heard amazing things about your program. Congratulations for the work you're doing in Brasilia. And we're going to talk a little bit about liver transplant and the standard technique. I would say a little bit how we do the transplant and some very common problems about cadaveric transplant. As you know, you had some problems, João. I spent the last 2 hours with the IT trying to fix my slides because I put a lot of videos and was not running at all. So I had to cut something. And if it doesn't run now, I have this part of the videos recorded for a previous presentation. So I show some slides, I play the video of my presentation, and then I go back to the slides. I'm going to try to go presenting, but if it doesn't work, I go back and forth. Let me share my screen. Can you guys see the screen? Hello?
It's okay.
Oh, can you see the slides?
Yes, you can.
You can.
All right, perfect. So if it's not running, please let me know. I just I don't see anyone, so I just have my slide in front of me. So liver transplantation. We're going to talk about cadaveric. How do I do? So just a picture of our medical center. We are at the University of Florida here. So for who doesn't know us, we are in a very small town in central North Florida with about 130,000 people, and half of them are students, 60,000. So it's a very small place. And what our program is, like our liver transplant in UF in the last 3 years. I've been here for 3 years. And pretty much the last 3 years, we did a little bit more than 400 liver transplants. We have a profile of a high MELD program. The median MELD is 34. About 50% of our patients are in the ICU at the time of the transplant. 99% 1-year graft survival. We have currently 30% of DCD donors, and this number is increasing very quickly. We have one of the first abdominal NRPs programs for DCD donors, the normothermic regional perfusion in US. We use as well a specialized liver ICU with lots of CVVH, MARS, plasmapheresis. We are ranking about volumes, top 5 in multi-organ when more than one organ is transplanted, and top 3 in liver kidney in the United States. We do almost about 25 to 30 liver kidneys a year. Our project volume for 2023 is around 160 liver transplants. Large use of positive serology donors and older donors. And 2 years ago, we transplanted the oldest organ ever transplanted in the United States, a liver from a donor that had 95 years old. And we do all the effort to have a very short ischemic time. I really think that's impact when you try to push the limits a little bit, get a fatter liver or an older graft. It's very important to keep this ischemic time low, and we try to keep below 4 hours. So these 3 years so far, we have like a very quick expansion, like I see in the picture of the right, but was tarmac, was tortuous but quickly. And now I feel like from the point that we are now, we're still not where we want to be. There's a lot of refinement that we need, but it's like to climb the Everest now. It's very difficult to get from the point to get the things for the next level. So just one of the things that I mentioned, we do a lot of multi-organs. So that's a picture that I don't get tired to see, and I enjoy very much. In the left is a heart liver in block that we do about 3-4 per year at least, and the organ that's going to go in and the organ that came out. And the picture in the right, it's one of the nicest pictures in transplantation that you see the heart surgeon sewing in the heart, and I'm in the side sewing in the liver. So 2 distinct teams sewing the grafts at the same time. So I think that's a very nice picture in transplant, and see like how the team work really in a high level. So that's just to have a picture that for Gabriel that doesn't know our program, and people that know, we have currently 1 year graft survival 99%. In the left was 3 years ago that the graft survival 1 year was 80%, and in the right is the latest report. And when you see the circles in the bottom, each circle is a transplant center in the United States. Lower the circle, better. So you see our blue circle very low in the graft. What gives a hazard ratio to lose a graft at University of Florida current 75% less than the national average. So something that makes us very proud about these outcomes. So quick hepatectomy using the piggyback technique. So I think in the United States now about 30% of the centers still using like what's called the convention technique. when they do like resection of the vena cava. I know there's a lot of centers in Brazil that still use it, that technique. Here, and in most of the centers, we do the pigback. So I don't really believe there is any difference between the pigback and the conventional regarding outcomes. I think nowadays it's more a surgeon's preference, very similar outcomes and complications, and of course there's pros and cons for both of them. For the students that watching, like when you talk about conventional, we resect the native vena cava and you end up doing two anastomoses, one above the liver and one below the liver. And when we talk about pigback, we preserve the vena cava of the recipient, and we can do different types of reconstruction that you're going to see a few slides ahead. So the conventional was the only technique for a few decades. Professor Starzio, that Gabriel had the opportunity to spend some time and do a documentary with him. That's very nice, and I'm very jealous of him for that. Dr. Estados used to say was not so happy about it because only few surgeons in the 80s and the early 90s were able to do it because there was very poor tolerance of portal and cava clamp at that time. Anesthesia was not that developed, and that's a cause that many patients die at that moment. In 84, the Pittsburgh group with a publication of Bayer Shaw, still Dr. Starzio, they came up with the bypass and then make the transplant a more stable procedure and easier to replicate. The pigback was described initially by Roy Ken in the 60s in an experimental model, but the first series was published and popularized by Dr. Tizakis in 89 and the early 90s. I remember Dr. Sergio Mies telling me that the first pigbacks in the 90s, they very, very scared to do this operation, to play with the vena cava, with the liver attached, like people were like dying. Every surgeon was very scared when they start changing the technique to the pigback. So when you look in the right, without the conventional technique, where you clamp the vena cava and the portal vein, you have like splenic congestion. That some patients with good portal hypertension, they're going to tolerate better, but some patients that doesn't have the portal hypertension so developed, they won't. And the bypass is like when you put like a cannula in the infravena cava and another cannula in the portal vein, and take the blood out and going back to the neck or to the axillary vein, giving more stability because you can run like 1 to 3 liters in cannulas. And some centers, some big centers, still do this approach as a routine. I believe that's a little outdated. May still have some indication for few patients. And nowadays, I would not use the bypass circuit. If you have to use that, probably use a VV ECMO circuit that has less complications. So that's a picture, Marcelo, that picture is from a pigback case from Albert Einstein Hospital in 2006. What by coincidence was my first pigback. So I think Dr. Bahia that helped me and mentored me in this part of the operation. So we see the vena cava completely dissected and completely separated from the liver. This vessel loop is around the right hepatic vein, and you see several ties on the multiple branch and the short vessels between the cava and the liver. So the steps for a quick hepatectomy, I divided for the presentation purpose in 8. Incision, the ligaments, the hilum, pigback from left side to release the caudate lobe, pigback from the right side, right hepatic vein, middle and left hepatic veins, and the preparation for the anastomosis. So that's the incision. In the great majority of cases, we do the incision now a midline with extension to the right. That's the incision that's more used to
Somewhere in the middle.
from the incision that's used for all the hepatobiliary cases, most hepatobiliary cases, and for all the liver transplants. Certain situations, we still doing like the traditional and always good Mercedes incision, or extension infraumbilical when you sometimes you have a jump graft to the aorta, and you know, but basically the great majority is the or J incision or inverted L or Makushi, how you want to call, but it's midline with extension onto the right. So the next is the release of the ligaments. So you get the false form, the left triangular ligament, and the right triangular ligament. Just to mention, all these drawings are from Dr. Romero Esmeraldo from Fortaleza, that when I was a fellow in Indianapolis, he spent some time there. And just observing the cases, he made all this amazing illustration about liver transplant. So here we see in the left picture the left ligament being released, and the picture in the right, the lesser sac, the gastric hepatic ligament being released.
Try to get the light, Brian, please.
So that's the false form. We're going down the false form until you get to the vena cava, very close to it. And after you find the vena cava, you go and go to release the left triangular ligament. So I like to literally grab the left lobe with my right hand and pull down, protect with my finger the stomach, and open with the bovie. Another way to do, and a lot of people, I think the most popular, you put a lap sponge there and you pull the left lobe down, and with the bovie you end up opening. So once you find the left hepatic vein there, you can lift your left lateral segment, and then your assistant is gonna, with a pickup of his hand, is gonna like lift it up the lesser sac. You see the window and you're gonna open. Very often you have varices or left accessory artery there that you have to tie or clip. In this situation with the bovie, we're able to open without any bleeding. So after the left ligament is released, we go to the right side. In the right side, we have the right triangular ligament and all the peritoneal that is attached to the liver to cover the vena cava and the adrenal glands.
Okay,
There, the right triangular ligaments are being like taken down with the bovie. So you take down, you're able to mobilize the liver a little bit lower. You ask your assistant with a pickup to grab the diaphragm and the take away to present where the plan is. Most of the case, you're going to have a very easy plan to go, and pretty much you're going to dissect until you find the right hepatic vein there. But sometimes you have to keep going back and forth with that exposure that you currently see. But also you lift the liver up, your assistant pull the kidney down in the bowl, and like 1 centimeter from the edge of the liver, you open a line with the lateral cautery to expose the vena cava. So the gallbladder is stuck there, you just go. You see the bulb is very hot, you see some flames. I think that this part of the operation, if you know exactly where you're going, it's the best one because all these micro varices, it takes care of it. And you go, we release the peritoneum there, and then you have like some room to go back up and clean a little bit more. When you see, I'm able to bring the liver down a little bit more, and then I found more tissue to be released until the liver is completely free. So just hanging by the hilum and the vena cava. You see the vena cava suprahepatic there, the hepatics, liver is free, and then you go and go to the hilum. So the hilum, three standard structures: hepatic artery, bioduct, and portal vein. So first, like I open a line pretty much between, in the middle between the liver and the duodenum. Because it's a cadaveric transplant, I don't need a length from the vessels, different from living donor. So wherever I found the structure, I'm more than happy to tie, because I'm going to dissect down the artery, and the portal vein is easy to make extra length. So again, with the Bovi, we open this line on the top of, you can see easily where the artery is. There's some extra tissue. And once you have all this peritoneal that's on the top of the hilum, the duct, around the gallbladder, then you can dissect and move like with the ties in the artery. In general, the artery is the easiest and the first structure to be tied. Sometimes, some cases, the duct presents itself in a better way, but in general, the order is like artery, bioduct, and portal vein. And again, I don't make any extra length. Whatever I found the structure, I'm gonna dissect and tie, because we don't need for a cadaveric transplant. As you see, I don't like to put that bar, inferior bar. I like to have an assistant that pretty much is my most experienced surgeon. That's going to control the operation, exposing the liver, retracting the bowel. When you put the liver in, it's going to give the good presentation, allowing us to see very well. And in general, like in the first assistant, we have like a resident helping, and but I prefer to put the experienced surgeon as a second assistant, because he's going to control the operation. At this moment, usually I change the hot Bovi to, we work with two Bovis, two electrocauteries, one at 120 and one at 40. And now at this point, we change to the lower Bov to don't take the risk to identify, to injure any vessel. So when you isolate the hepatic artery, you can spread the right angle behind. It's easy, it's safe. There's no extra vessels. You don't have to be concerned to injure. We cannot do the same in the bioduct, because you're going to injure the vasculature. There's some varices, always some little branch that may bleed, and you can tie or clip. But in general, the three big structures are the ones that you really have to tie. So for the videos, in your end, you can see the video clearly, or it's like, or it's not running well.
It's pretty clear. Yes.
Good, good. So far, no
Absolutely
problem.
perfect.
So the hepatic artery tie, I like, you see, like I put the tie first on the top where I'm concerned to make more room. You see, I move my body to the left so I can pull the tie down. It's something that my boss and my trainer, Dr. Tech, was very keen about it, and I still do the same. always like moving the body up and down to better find a better position to tie. We put the right angle to protect and keep the space for the tie in the right position, moving the body again lower, we're making space with the tie, and in general, using a knife, number 15 blade, to cut the artery and the bile duct and the smaller structures. So after the artery and the bile ducts, you repeat the process with the bile duct. Once you take the artery, you can in general identify where the portal vein is. And the only thing you have to do without much dissection is slide your right angle on the top of the portal vein. And I like to get a lot of tissue with it. I don't dissect much and divide it. Then you have the portal vein that you're going to skeletonize. There's some like tissue around after you take the duct and the artery, still some lymphatics, and might have some right replace artery. We're gonna find it there behind the portal vein or just lateral to the portal vein. But you do like a movement like I did, go behind and invert. And with a Kittner, we make extra length. And that's one of the difference now. If the patient has portal hypertension, is a chronic liver disease, I like to take the portal at this time. That's going to save me a lot of time of in the hepatectomy. And I'm going to show why. And also, it's going to give me the possibility to flip the liver not only right and left, but it's going to let me open the liver like a book. Use a stapler to divide the portal vein. Here another video showing that taking with the stapler the portal vein, the structures. Then you have like the portal like a line pretty much. It's easier when you're going to put the liver in. And again, I like to do at this moment if the patient has portal hypertension, because it allows me to do like a very quick hepatectomy in the piggyback technique. And that's the reason. When you see this picture, you can open the liver not only right and left, but you can open like a book. And you have like a huge and beautiful exposure of the vena cava. So here, for example, I have the liver under my left hand. And then I open the peritoneal on the top of the vena cava. The image is a little far, but the assistant's holding the bowel there. And this patient's kind of had peritonitis. He's going to let it go and doesn't move. It's kind of those type of patients stuck. And that's another benefit if you take the portal at this stage, because when you tie, and you're going to see what you're going to do, he's tying out the branch. I can just tie one side. There's no bleeding. So I save a tie in the liver side, and that's going to save me time. So after I open, I keep opening all the peritoneal in the left side. Initially, early in my career, I used to do everything to the left side, but I started doing as much as I can to the left. And João knows, like a technique described by Professor Beduschi, that doing this approach of the piggyback through the left. You see, I have the turntable towards me. I have a great exposure, and I like to clean as much as it allows. Some cases, the caudate is not very easy from the left, so I approach entirely from the right side. But whenever you can do from the left, even if it's just clear the peritoneal, I see advantage because it's going to save you time in the end. It's going to make your life better once you have this clear. and you go up to the cleaning up to the vena cava and the hepatic veins as well. So once the portal vein is taken, should not take you more 15, 20 minutes, 25 minutes at the most to take this liver out. Otherwise, you're going to have a portal clamp for too long. So another branch there that the assistant is gonna tie. You can see it's a great exposure. It's safe. If I put a hole in the cave, it's easy to put a spoon clamp or put my finger and have the situation under control. And then I use the pediatric suction that you're gonna see now. That is blunt, small, delicate, blunt, doesn't hurt the tissue. You're going to see some. So once you have this major branch in the caudate and you cut, one maneuver that I like to do is to get a spoon and grab in the tip of the caudate and lift it up. That makes that's a different case already. And you see with the pediatric suction and the traction with the spoon in the tip of the caudate, even if the caudate is very stuck in the vena cava, I have a good presentation, and I can do the dissection very well. So again, I believe this instrument, the pediatric suction or the baby suction, is probably the best instrument to do this dissection, because the tip again is blunt, keeps sucking the blood out of your field, and is delicate all the same time. And again, you keep tying just the cava side. You don't tie the liver side because the portal is already gone. And you're going to advance quickly north. And some of the cases that you do to the left, you're able to dissect absolutely everything. And pretty much when you turn to the right, you have just the right hepatic vein. So it's a very good and effective approach. And you keep with your pediatric suction, cleaning the field and dissecting. And you see some major branch that more in the right side, but you can approach through the left. It's very easy to see it. So we're like surgeon and assistant there. Ideally, I always tell liver transplant is for 3 people to operate. So the assistant has to do more than one task, but it's okay. Ideally, 3 people. Big suction going around the branch, easy to identify. So maybe you can tell João that was the French contribution to liver transplantation, huh?
Yeah, I think so, from Professor Beduschi.
So I have to admit that I was like one that I trained like this, approaching only to the right, but I evolved to do this approach that I go initially to the left and doing as much as I can. So this video, sorry, that was done like probably 2021. Is like I had literally this is my assistant that has a GoPro in his head, but the other ones is like I have a GoPro in my head. Nothing much fancy. I don't want to go too forward because I'm afraid the computer is gonna get stuck. So it's almost gone. We move to the next one. And you can go up to the level where the middle and left are there, and literally have it clean from the left. And I don't like also, some people like to use ligature or some of these energy device in the smaller branch. I don't think it's good because in the end, the patient can get overload afterwards and end up bleeding in the ICU. So here's the approach when you turn. Once you clean the left side, you turn the liver to the right side, and then you're gonna go find the right hepatic vein. And you're gonna clamp them separately to make the exposure better. So the liver now is turned to the left, the table is turned to the left. I think that's the same case of before. So you see there's a couple more branches there that I easily, with the PD suction, identified and tied. There's no addition there. It's like the moment that we turn around. And your cava is the liver is hanging by the hepatic vein. So using the PD suction again, I make a tunnel when I identify the right until the top. I don't like to clamp. When I train in Brazil, I learned to clamp all the veins together, but I think it's not nice. I prefer to do this clamp on the right hepatic vein that you make the tunnel. It's clamping now. Getting extra length in the vessel. So when you're going to put the clamp, you try to do a partial clamp of the vena cava and not a total clamp. So that's promoting more hemodynamic stability. So so that's the right hepatic vein clamped. And we may have one or two branches before the final clamp of the middle and the left.
Hold the liver, please.
So then you dissect and you're gonna clamp the middle and left hepatic veins, and in the picture in the right you see how it's gonna be one clamp in a vertical and another clamp horizontal. So Satinsky in the middle and the right, the middle and the left, sorry.
Scissors.
And then your hepatectomy is finalized.
Okay, liver valve. More.
So I apologize for the blood. There's no addition. Is life as it is.
Okay, any spoons?
So then this part now, you see, I'm gonna change I'm gonna put several spoons to pull up all the hepatic veins to clamp as minimal cava as I can. So some people like to do this with Alice. I think the spoon is a better instrument because it holds better, it doesn't hurt the vessel. So you see all in the extension of the middle and left, I put spoons. Then I release the clamp. And then now I have to change the orientation of the right hepatic vein because it was clamped vertically and I have to clamp horizontally to follow the same orientation of the middle and left. So I put spoons initially, and then I reclamp with a Satinsky.
Triangle first.
Sometimes there's still some tissue between the middle and the right, so we should take that tissue down so you can really clamp the vein.
Okay. Okay, Satinsky. Same one. Just like that. One thing I still have to pay attention is what side you give me the instruments. You're very often spelling the upside down. Pick up.
So now we replace the spoons in a horizontal because the clamp is horizontal. So allows me to clamp the three veins together, respecting the same orientation.
Ready for clamp? Okay.
So in the bridge, I put another 1 or 2 spoons to grab extra tissue. Otherwise, you don't have enough when you put the clamp. You're going to cut that after the clamp is placed. And in this case, you're going to be like, I put a big Clintman and clamp. Checking the cava to see if it was partial. Was not total, but it's going to have some hypotension.
Well, I need a big, little medium to big triangle, bigger than when I use it and pick up. Well, I have clamp already, no spoon. Can you work it out?
So anesthesia complains some hypotension.
Pick up and triangle. Mike, you need Brian, you need scissors. And pick up. Let's go, guys.
So with a little bigger right angle, go to the right hepatic vein, get out in the left, and that bridge that we grab with the tail, we're gonna cut it. Make a common ostium between the three veins.
One to the bottom, yeah. Silk for all stitch.
A couple of stitches between the upper side of the ostium of the hepatic veins to the diaphragm to keep it open. So just to make it easy when you're doing posterior wall and to don't let the tissue to slip away or slide through the clamp that sometimes it can happen.
A lot of silk. Put it on. Okay, I need a 3O proline.
So we do the vena cava anastomosis with 3O proline.
Scissors. Scissors and 3O proline. Okay, he's gonna need rubber shot. Rubber shot. Got it.
So here, just an illustration of the spoons pulling up the vena cava, and then you opening that we clearly saw, and that's the stitches in the upper face, looking the cava ready for the anastomosis. So that's a picture that I got from Professor Mies many years ago for a talk. So the options that we can do in the pigback, right? We know that in the conventional technique, you're going to do upper anastomosis and lower anastomosis, very straightforward. some people and in my training, they used to do a lot. They close the right hepatic vein and do middle and left. I don't do at all this option. I think it's not a good choice. The anastomosis is going to be small. It can rotate and kink, and you're prone to more complications. That's the first picture in the upper left. The right left is an anastomosis we're doing like, and I do sometimes depending to match the size of the cava. And I think Professor Massarolo, mentor, I think it's Fabrizio of the liver group there, a PhD thesis about the size of the vena cava in cadavers. And they saw the size that match more will be opening the right hepatic vein and the middle hepatic vein. Sometimes I use this, is the upper right picture. You overshow the left hepatic vein. The lower left is the one that I use the most. That's the three veins that we saw the preparation in that slide. And the lower right, and I think that's what Marcelo does as a routine, is the side by side anastomosis or cavostomy. You close the vena cava up and down, and you make an opening in the posterior face of the vena cava of the graft, and you put a big Satinsky or other type of clamp. The advantage of this technique, in general, you clamp partially, and you have more hemodynamic stability if the patient is not very stable. Sometimes when you do the clamp of the three veins, we try to do partial, but not always we achieve that. So for that reason, sometimes it's good. I don't do very often, very rarely. I can count in one hand the times that I did side-to-side anastomosis. Most likely, I think when you have a pediatric graft for a bigger recipient or a big recipient, and the torsion of the veins is a problem because the anatomy, I think you put in the liver where it's going to sit and then do the anastomosis. I think one of the indications that I would do it. Several groups in the United States, they advocate for this side-to-side, and they're very adamant about it, but it's not my preference. So here is some like real boards of the time. Using this hepatectomy technique, we're able to do the first line is the time of incision to the liver out, 49 minutes, 60 minutes, 44 minutes, 53 minutes, 58 minutes, and 60 minutes. That's like 6 cases in a row when you're able to do these videos. And the bottom time is the total time of the transplant, 2 hours 22, 2 hours and 40, 2:30, 3 hours and 40. A patient requires a Roux-en-Y, 2:39 and 2 hours and 50. So it's very feasible. You can replicate easy this technique, and it's very efficient. Liver is out less than 1 hour in most of the cases. And if the time of the transplant is pretty much dictated by the time of the hepatectomy. If you have a fast hepatectomy, you're going to have a fast transplant. So you finish your transplant in less than 3 hours most of the cases. So at the end of the training, you have to develop your routine. Always do the same way. More important than that, to be always safe, to do what like good exposures. One of the criticisms that I have, some people that like the side-to-side, they don't expose the way that you saw the cave exposed in my case. They kind of dissect from the top, and then you don't have like, I don't think it's as safe managing the vena cava as you saw with a lateral approach. When you approach the cava from the top, I think is bad. Train your team, make it simple, cut steps that's unnecessary. This operation is already complex enough. You saw during the hepatectomy, I used 3 instruments: spoon clamp, pediatric, babe suction, and right angle, and that's it. Once the section and the bovine. But more important than that, you have to feel comfortable with your technique. That's what you used to do, and you do well. So despite it's not, we don't use as a routine, I think the convention is always a great option, or I can even say that always the better option when you need. When you have to convert, the veins are not good, the liver is stuck, is bleeding, you have to have a quick approach. I don't hesitate to put a big clamp on the top of the liver, a big clamp in the out. I tell the anesthesia, bring more blood, and the liver is coming out. So you have to be ready to be that. So conventional is very important to do. So more important for me than the side by side is to have in your arsenal, in your options, the good conventional. And every time you have a question about outflow, you have to go back, and the way to fix and the way that's safe is the conventional. A hepatectomy and hepatic phase should be as quick as possible. Allow a reperfusion of the graft in 2 hours or less. Why I say that? If you're going to take 2-3 hours to reperfuse after the graft comes, that's going to limit your ability to use a graft with 40-50% of macrosteatosis, because you have to minimize the ischemic time. Otherwise, this graft is not going to work. So as fast as you can go, it's going to amplify the amount of grafts that you can use. So if you're going to take more than 1 hour for this liver to come out, or more than 20-30 minutes after you clamp the portal vein, you should consider either doing a portal cable shunt or bypass or VV ECMO to make sure that you decompress and you don't get in trouble. That's most important in patients that don't have chronic liver disease, so they don't have this portal hypertension, and that includes fulminants. They not going to take the portal clamp very well, and patients with tips. I have situations that when the patient has tips, I don't clamp the portal at that phase that I showed before. I wait when I have the piggyback done to minimize the time that I have the portal clamp. When you put a tips and the tips is open, it pretty much closes all the shunts that the patient has. So when the bowel is going to get congested and it's going to start putting pressure on your field and start bleeding more, and then you may leave a stable situation to like a situation that you really like in trouble. So patient that has tips or not portal hypertension, I avoid. I had an extreme case like a year ago that the patient had a tips, massive spleen, and when you clamp the portal vein, I was sewing the portal vein less than like 10 minutes after, 10-15 minutes after, and the spleen exploded. Such was the pressure. Was a near miss. The pressure went to 30s, 40s. I was able to put a big clamp in the aortic clamp in the tail of the pancreas, grabbing all the hilo and control the bleeding, but might be a very desperate situation. Be safe, good exposure, and good help. That's like, I cannot stress enough how much you need to have good people with experience helping you. So, few implantation topics. Unfortunately, the video of the sewing the liver in is one of this. We couldn't recover this afternoon, but I have a few things that I wrote that I think important and going to be good for the discussions. Again, have your routine. Always do the same way. Try to keep a short warm ischemic time. I try and I tell my surgeons, here's our goal is to keep 20 or below. I think 25 is good. Anything above 30, I think we already affect the quality of the graft. To avoid a bad reperfusion, on some patient some liver that's fat, the patient that's not stable, always flush the liver. Some people use ringer. Here I use a combination of saline and albumin in a room temperature. I flush 2 liters through the portal vein before do the portal vein anastomosis. And some situations we even don't tie the infrahepatic vena cava of the graft, and you flush after the portal vein anastomosis is done. We flush with blood to warm this liver a little bit and to take all the preservation solution out with that's rich in potassium and everything else. Portal vein anastomosis, 6-0-proline, 5-0-proline, it's your choice, but the length is very important. Keep it short. A lot of lap sponge behind the liver to bring this liver down. You don't want to be redundant. The artery also, I do very short. I use the parachute technique. I don't like to use patches. I cut the artery in general. I like to tie the GDA in the recipient to have the artery go down almost to where the splenic is. So I put a soft clamp there, and then do a very short as I can without using the patch. Always paying attention when you do older recipients. If there's some calcification or some narrowing in the celiac, I avoid, and even a good flow, I avoid tying the GDA because that may save you in the future. If that celiac narrow even further, you have the GDA open to provide a blood for your liver. Bioduct, in general, I do running sutures, 6-0 PDS, small ducts or ducts with a big mismatch interrupt. I don't put any stent. Duodenum is my second option when the bioduct is not available. I do a choledoc duodenal anastomosis. If there's a problem, the rule is always a good option and safe option. It's just more time consuming. Most of the cases, I still do the delay fascia closure. I don't like to close the muscles. I think there's several things in favor of that. There are studies that show that every time you close the muscles, 75% of the liver live with the bladder pressure above 25. That, by definition, already classified as some intra-abdominal hypertension. That's going to affect your urine output. That's going to affect the nutrition of the hepatocyte is in the venous phase. So any additional pressure may compromise the nutrition of the hepatocyte. You putting an 18-year load in a guy that of plenty of space is going to make a difference? No. But if you put like a fat liver, older liver with some tight cavity, I think closing the fascia right away is going to affect and is going to compromise the function of this graft. In these 400 cases that I'm presenting here, I don't have a single primary known function. And one of the reasons for that, and we're pushing a lot in the donors, I think is the fact that we keep the fascia open. That after 2-3 days, you go back, give you the opportunity to wash out clots, to look the artery, look the vein, and even redo the bioduct if you don't like, or if there's some stain of bile and things like this. Jump grafts, you have to know how to do it. Older your service and more like you start doing, you're going to have older retransplants, you're going to have patients with vascular problems. When you talk about arterial, supra or infra, one thing I prefer to go infra. I think it's easier. You pull the ball to your side, release a little bit the duodenum, and you get straight in the aorta. Of course, the patient has a lot of portal hypertension, a lot of varices, and is fat. It's going to be like you have to dig the aorta out, but in general, pretty straightforward. The iliac goes through the mesocolon. And when you do a venous graft, excuse me, that's the most sensitive way, because any angle or any area that is going to affect your flow. So we're going to dissect. If you don't have a good flow in the portal vein, is a bad thrombosis that you don't have, and you have an open SMV. That's the option. You dissect SMV, you put the iliac vein, you go through, and then you go behind the stomach. Some patients, and I found that some angles are bad, and it's not because the duodenum just doesn't let the vein has a soft curve. I had in an extreme case, and that's one case, I split the stomach from the duodenum. I staple to allow the vein to have a barrier, because I would lose the graft without doing that. So IMV, when you have like a sizable IMV that's connected to your splenic and SMV, I think is a good option. Talking about the angle, it's a better angle actually. It comes straight to the hilum, but has to be a sizable so you can do an end to side in the IMV, and the dissection is easier. But my preference is still to try to take the clot out. And some patients that have these big shunts, these splenorenal shunts, I always dissect, find the left renal vein, declot this small portal vein, and then I see the flow. Even without the clot, with these big shunts, you have a very low flow. I put a spoon, a clamp in the left renal vein, see how the flow is. Almost 100% of the times, this flow is going to enhance a lot, is going to increase a lot, and I proceed tying the left renal vein. I do as a routine, like when you have like low flow, and I know there's some shunts. So a lot of my patients leave the OR with the left renal vein tied. And of course, the renal portal is another option when you don't have any SMV, any portal vein, anything. I think is a better option than the portal cava, the renal portal, and you're talking just about liver transplant here. So a few things about just one slide about ICU that I mentioned. Have a specialized ICU, and I think to have like a good outcome that comes with it, you cannot run away. So we keep our patients very, very, very dry. Every time in my unit here, like probably I have 4 or 5 high melts in the unit waiting for transport or in workup. All of them are in CVVH. And when you look at their charts, you're going to find they 25 liters negative, they 40 liters negative. Usually they come from the community hospitals, very sick, intubated on pressors, and like with 20, 30, 40 kilos up his dry weight. And then start to work to remove this fluid, Doing that, going to the OR for a liver transplant with a very dry patient is going to decrease the incidence of toxubo post-op. We have in these 400 cases doing a lot of sick patients, and with this approach, I remember just one patient that developed non-ischemic heart failure, and that reverted over time. Need some support, but it got better. But one of the reasons I really believe that because we go to the patients extremely dry to the OR. Vasopressin, levo-fed, we use pressors to be able to remove that amount of fluid, make them negative 3, 4, 5 liters a day. We have to keep them pressors. What's okay? Albumin, bicarbonate, antibiotics, all very important. Then that most of the patients you get away with that. When you cannot, there's other options. ECMO, T4 drip. T4 is something that when you look the blue book, Paul Marino, ICU, famous ICU book called the Blue Book, there's one sentence that I found that the critical ill patient behaves regarding their hormones like a brain dead donor. That's all it says in the book. Then I thought, just a second, we do T4 drips or synthroid drips for absolutely all the brain dead donors. If our super sick patient behaves like a brain dead in the hormones, why don't doing the people that are alive? So we start doing that. It comes out, helps to come down with the pressors, helps to remove more fluid and everything else. Plasmapheresis pre-transplant we do for fulminants and some acute and chronic as well. We have a MARS program that we do for selected patients. IVIG is very important. When you check the IgG levels of patients when liver failure, the level that's supposed to be above 400, 500, 600, depending on the age, you're going to find extremely low levels. And remember, and that we learned from pediatrics, from bowel transplant initially, and we pretty much moved to the liver. And these are replacing when the IgG levels go below 400, the patient lose part of the ability, lose the humoral defense, losing the ability to fight bacterial and viral infection. So you have to pay attention that to replace. So liver ICU should work as a bridge. So again, I think that's all I have for today. I really appreciate the opportunity to talk a little bit about our program and the things we do here. Dream, believe, deliver. And there's a lot of ICU things, and maybe is a conversation for next year, João, liver ICU. Thank you so much, and I'll be happy to answer any question.
Thank you. Thank you, Thiago. Yes, the other times that you have presented here, always very interesting, very amazing presentation every time. This one was really one for surgeons, because you showed all the small tips, and I think it was very, very interesting, especially for us. I think that now probably I'm going to invite Gabriel maybe to start the the first question to you, just to check if he does it pretty much the same or if he has other sort of ideas. So Gabriel, could you please start the discussion?
Yes, please. Thank you so much. I would like to congratulate Thiago for his quick and strong start at the program. I saw him when he was moving from Miami to the University of Florida. I had to congratulate you because you did a wonderful job, and we will keep growing and moving the program forward. It was very interesting for me to listen to your talk, because it looks like we train at the same place, which is not the case. We train in different places, but I'm pleased that probably the experience and the number of cases brought us to similar conclusions, and we perform our transplants very much unlike you. Probably based on your descriptions, I found a couple of differences, which is we use in most of our cases piggyback technique as you do, but usually probably we use half of the cases we oversaw the upper cava to the opening of the 3 suprahepatic veins, but in the other half we use left and right and middle, but with a little difference. Instead of using only left and middle, we try to use a technique that was described by the group in Milan, where they clamp the cava and they do cavoplasty. Therefore, it's not that you use only left and middle, you use left, middle, and 1 centimeter over the anterior wall of the cava. And certainly I must to tell you that since we do that over the last, right now, 16 years, we did not have 1 single case with a kinking or with suprahepatic issue and problems. Nevertheless, when we train our fellows, we always favor to have them as going around the 3 suprahepatic veins. But that's something, the use of left, middle, and cavoplasty is a very safe technique, at least in our hands. And I think that I like to do that a lot. Mainly when the right hepatic vein is very separate from the liver, the left and the middle, and also they are in like a 90 degrees angle. It's not like usually are like this. They usually are in the opposite direction. And sometimes it's not easy to grab them completely, but that's something that we most commonly do. I think that probably the most challenging thing for the people that is training, and you describe it very well, is the artery. And I think that the fact of performing short arteries and also using parachute is what I found probably the most important, or the most nice ways to do them. We also measure flows after doing the artery. We have a flow meter, and we try to assess the flow before sending the patient to the ICU to be sure that the artery has no problems, but certainly make it short. I always tell the fellows that once you put the liver in the abdomen, one important thing is don't don't drop the liver, but you have to, to accommodate the liver to the position that it will fit after, because when you close the patient, the liver moves a little bit from up to down and from the left to the middle. And that's where the kink might occur. And I think that's something that we do. I also can comment on something that I really value, your approach and your advices regarding the tolerance from the clamp in the portal vein when you have tips. And it's that important that we usually, when a patient gets admitted in the hospital and has a history of tips, we tell the fellows to do an X-ray, an abdominal X-ray, to see the position of the tip itself, because sometimes the tip moves, and that helps you when you pursue the approach to the portal vein. And sometimes you find the tips all the way up into the heart, and that's something also that you have to be very careful when you clamp the hepatic veins, and you sometimes have to remove, wire by wire, all the tips that are crossing into the hepatic veins to be able to perform the safe upper cava anastomosis. But certainly it's a big challenge, because if you don't pay attention to this detail, you can have a sudden bad outcome with the patient in the operating room. And I certainly also value your approach. I would also like to ask a question to you, is if you have any consideration when you do duct-to-duct anastomosis regarding if you cut the donor port bile duct above or at the level of the cystic duct to be as short as possible as well, to avoid ischemia in later. And after say so, we'll open discussion to somebody else like Marcelo or Andre. And congratulations, Thiago, you have done a wonderful job.
Thank you, Gabriel. I think your comments are spot on, and I think you do this plasty in the vena cava comes from pediatrics. That's a very common technique in pediatrics. You opening vertically down and making a little bigger. That's a common approach for pediatrics. Regarding the bile duct, and again, I said that I don't do about the left and the middle. Was the choice approach of Joe Tector that who I train with, and we all have an doctoral experience, right? And I remember like he doing and the kinking and having a clot and being in ICU all night. I said it's not working, you have to do something, and he like, yeah, forget about it, it's okay. And that's like a kind of traumatized. I have the PTSD about that, and I end up kind of abandoning that. The bile duct, I don't dissect much. I always trim a little bit, both. The tie that I put below, I just cut the tie, cut the duct, blades, I stitch around, and in the top, I just trim another few millimeters, and is always bleeding, and but I don't specifically go above the cystic. Sometimes I use the cystic with a ductoplasty in both sides to match the size of the other duct. But I don't specifically look for it to go. I just trim it.
Marcelo, do you have any questions?
Thiago, first, congratulations and thanks for your great presentations. For me, it's very impressive. It don't matter, as you told us, it don't matter if you do standard or piggyback technique. But for me, the great message was that you are doing 50% of liver transplant in the ICU patient and 50 with a very high MELD with 90% of surviving in the first years. It's a great result. It's difficult to do that, and I congratulate you. As you know, you are used to do a piggyback technique with lateral approach. I'm not really agreed that is different in results, as you told us. The papers are not showing different outcomes. But I would like to ask you, for me, is the great thing is you could use a piggyback, conventional piggyback or lateral piggyback, and even a standard technique if you do a very short hepatectomy and implantation. But for me, it's difficult to choose or I'm asking you is how, when you decide to do a standard technique before liver transplant. I mean, there is any case that you see and say, no, this case I'm doing to standard technique. And if you decide that, when you decide to use a venous bypass or ECMO before in your in your meeting, you decided to do a technique.
So thank you, Marcelo. And for who doesn't know, the place that I trained was a different group, was Marcelo's hospital. So I have a lot of affection by Albert Einstein group and everything I learned from that great hospital. Yeah, there are situations that we go like already thinking, despite sometimes the classic indications, right? Body Chiari, for example. You can piggyback, yes, you can, but sometimes not safe and not worth it. It's easier you go there and put a clamp and get it done. A polycystic liver, the same. I did several polycystic in the beginning of my career that I piggyback. I piggyback them all. Is it worth it? I don't know. It's a very dangerous operation. Depends who's in front of you assisting. And I know several cases that the liver is very heavy, and when you're approaching the hepatic veins, it's not difficult to tear everything. And then you can have a major catastrophe. So these things, like you can already anticipate that you may need, or likely you need, to do conventional. So when I know a patient that is going to need the conventional technique, what I do in January, since we don't do bypass as a routine, we're not familiar. We're not like, let's put here. So I tell we're very close with my thoracic friends, the ECMO, the people that run ECMO, and I keep them in standby. So, and usually if the situation allows, that's not always, but if the situation allows, you can do the test. You clamp the hilum, put a clamp in the cava, and you see how the patient behaves. If you have this opportunity, and if it's not very well, because you can call for the bypass. But in general, the anesthesia, the way that the knowledge that they develop, they can control most of the cases.
Yeah.
It's not about hemodynamics. For me, one of the major things about the bypass is decompress the splenic system. That can be catastrophic if everything is exploding in your face, in terms of bleeding, in terms of everything. So you decompress that. And another thing that I like and works, like if I know that this patient needs arterial jump graft, a retransplant, for example. Okay, you dissect, you take your time releasing the liver, there's no artery. You dissect the portal. Before taking the portal down, the liver is still in place, it's free, you're almost done. Go there and I put the jump grafts. That's going to save you a lot of problems because you don't really know how this patient is going to behave after the portal clamp. You put the portal clamp, you take the liver out. If they start all the bowel swelling, everything else, you may get in trouble. You don't have an artery. May take some time. So to anticipate potential problems, I think to be proactive regarding this, either trying to the clamp test, calling the people the bypass people, having the things handy that's going to be quickly available. I think you increase your chances to succeed or decreasing catastrophic events. So, but I would say, of course, patients, polycystics, body Chiaris, that would be the measure. Or patients that are super sick with cardiac disease, that you don't want to stress the heart to the point, you want to keep like more stable. So those are patients that would maybe benefit for a VV ECMO.
Okay.
André? Oh, sorry, Marcelo.
Okay. Thank you.
Sorry, if you have further questions, just go.
It's okay.
Okay, sorry. So, André Watanabe?
Hi, everyone. I want to congratulate Thiago for this great presentation. And as Marcelo said, it's very impressive, this result, using all these DCDs and these very ill patients. Yeah, you achieved 99% 1 year graft survival. And I think that is amazing. And I try to learn here today from you these key points, how to get these amazing results. And I want to just tell everybody some of our experience here in Brasilia. You said that you get a very short ischemia time. That's great, but it's not our reality here. Most of the times we get more than 10 hours of ischemia time because we have a few donors from our state. We have to go to other states and our logistics are not very good. So our ischemia time is very long. About the technique, and I think this presentation is definitely for surgeons because it's all about technique. I saw that you take down the portal vein very early in your procedure, and I think this really facilitates the pigback and to take down the rest of the liver. And I want to ask you, I saw some groups that routinely do this portal cave anastomosis, and I want to know if you do this sometimes. I think in the USP, they do all the time this portal cave anastomosis, and something that we don't do this here, but as you take down the portal vein very early, if you do this sometimes. Another thing, most of the times we along our history here in Brasilia, we did the cave anastomosis just like you, using the 3 veins. But nowadays, especially this year, we have already done 42 liver transplants this year, 2023. Most of the cases we're doing the anastomosis with the middle hepatic vein and the left hepatic vein. We are ligating the right hepatic vein, and you said that you never do this, but we're having good results. We're gonna let's see how it's gonna go. But so far so good. And another thing that it's really interesting is about the delayed fascia closure. Something that we are doing here for these very ill patients like fulminant hepatitis and patients that very high MELD. We're not closing the fascia anymore, and we are closing this 2, 3, or 4 days after the transplant. I think this is a very good approach. We are seeing some incisional hernias after that. I don't know if it's related or not. And another thing that I wanna ask you is specifically about patients, and you have to do hooks and Y anastomosis. We are doing a lot of cases, patients with a lot of previous biliary procedures, highly infected patients, and many times we did this hooks and Y in the same procedure with the transplant, and we saw a lot of fistulas, and this was something very catastrophic for these patients that we have to operate 5, 6, 7 days after the transplant in a very bad condition. So we are trying to do staged anastomosis, biliary anastomosis in this case, like a secondary biliary cirrhosis. These patients with after COVID cholangiopathy, with a lot of previous biliary procedures and with a highly infected liver. We are doing this hooks and Y anastomosis 3, 4, or 5 days after the transplant. We did not close the fascia, and we do the biliary anastomosis in this case, and the second approach. And we are seeing a lot of good results. We didn't have any fistulas after that because we take out that infected liver. We give antibiotics to the patient, and we have a good result after that. So these are my comments. And again, I want to congratulate Thiago and all your team and your ICU team and your surgical team. This is a very, very impressive result. And I really want to learn from you and all of your experience and gains you. Thank you very much.
Thank you, Andrea. Thank you for your comments. First of all, maybe the way that I told, it looks like my service is like a rainbow, right? It's not. If you go, there's like people, I have a very long length of stay because we do this super debilitated, no muscle mass. Patients with the cubit ulcer, it's not like they surviving, but it's a long journey for these super sick patients. Regarding the portal cava, yeah, I do occasionally. I think if you want to take the liver out, sometimes maybe to facilitate your piggyback in a fulminant, I think it's worth to do it, for example. So you don't get like congestion of the bowel and get everything very swollen. But again, as I told you, if you're able to take, once you mobilize, you have the liver mobilized, you dissect the hilum, you staple your portal, and in 15, 20 minutes, you're able to take this liver out. I don't think in patients with portal hypertension and chronic liver disease, you're going to have a difference portal cava there, because the collaterals are taking all this blood and the bowel is not getting congested or anything. So I don't see much benefit. I know some people do as a routine, and in general, people that train in France have this approach. But the case is like when any other situation, when you clamp the portal vein and everything got very swollen quickly without you expect. So then, yeah, as a rescue maneuver, you can quickly put a patient. And you're going to see that specifically in the patients that have the umbilical vein that big. Some of the patients that we see, when you clamp the umbilical vein, all the shunt is gone. Some of them become like you open and you have to clamp. So they become hypotensive on that. Those patients, when you take the portal vein, they're going to suffer. So that may be a patient that I would consider more a portal cava shunt, and a patient with tips again. Anything that's not going to get swallowed in the gut. So about the fascia closure, I think your approach is perfect. Again, do we have to do for everyone? Absolutely not. I decide as a programmatic to do on everyone because we have different surgeons, different judgments, and I want to have like a programmatic approach. So, but if you consider the rate of XLAP or reapproach the patient after high melts, there's a national study that show almost 50% goes back to the OR in the first few days for high melts. If you're doing a lot of high melts, I think is to keep them open is an advantage, because half of them would come back to the OR anyway. I have an experience a little bit different than you about the bile duct anastomosis. I don't like to put a tube. We do sometimes on this catastrophic transplant. They got like 100 units of blood and you like exhausted. You don't have like everything is, you're like, you know what, I'm going to put a tube, get to the ICU, and I figure out later. I think you have a higher incidence of complication when you put the bile duct. Maybe you tie, you get the duct more ischemic. I think probably your leaks are because bowel edema. Probably the small bowel is congested, some edema just after the transplant. So maybe the duodenal is a better option in those situations, to do a cholerical duodenal that more and more people are using, and is easy, and the IRCP can easily fix. Although I have to disclose, this year we did a cholerical duodenal that had a leak. It was not a leak, was pretty much a dehiscence. So we tried with the ERCP, but was so much well, half of the anastomosis was gone, and we end up converting in a Roux-en Y after a few days. But that would be my approach. To play with the bowel in the first moment, I agree with you. You have congested edema, you're more like prone to leak. So you have to be very, very tight. And I like the approach, and I did that in bowel transplant, that I like to call the 3 layers approach. I do the external layer, interrupt to silk, PDS running, and then between the loops of the PDS, I like to put interrupt silks tight. So that way, if there's some edema, it holds things together. That's a personal approach. I don't know if it works different or not, but I like to do that. But those are my comments for Rod, and congratulations for the great program that you developed in Brazil.
Any further question from Marcelo, Gabriel?
I think that I would like to make a little comment, and I think that regarding ischemia times, I do agree with Thiago. We have also a large country, and for example, when you have donors from Tierra del Fuego all the way down, we need 4.5 hours to go to Buenos Aires by plane, and with a refill sometimes in between. Similarly, we have a problem when we go to Salta, or back in the north. Probably the difference between some countries and our countries that we are allowed to start the recipient operation when the plane takes off. Therefore, our mean ischemia time is 6.5 hours, 15 minutes, independently of the place where the organ is. And I think this is an approach that should be taken when you live in a big country in order to facilitate. If our procurement team says that the organ is appropriate, we start the surgery in the recipient, we don't tie the artery, we build everything around, we even have the piggyback completely down without tying the artery of the portal vein. And when the liver arrives, then we do the back table quick, take the liver out, and sew the liver in. And that allows us to have, and I agree with you, we do Hyman scores not as high as a mean average like you do, Thiago, but we have around between 28 and 32 of real melt also in our country to transplant patients. And because of the lack of donors, we are increasing the number of adult living donor liver transplants. And last year we have performed 12 living donors in 1 year for a total number of 60 transplants, which is a significant number. And we are right now doing the right lobe donors laparoscopically, which also seems to be a good approach for our patients as well. We use a lot of split transplants, and we publish about that. And also, I agree with you in the indications for a standard technique, adding when you have a surrounding caudal lobe that sometimes it's hard to peel it off the cava, although you can do it in most of the cases. But that will be probably my third preferred indication for or to perform a standard technique. Otherwise, I completely agree with you. Once again, congratulations, Thiago. Great to see you today, and the same to the rest of the colleagues, Marcelo, Andrea, and thank you, Thiago, for the invitation.
Thank you, Gabriel. Let me just agree with you as well. We do sometimes often as well to start the case before. For example, we get a lot of livers from Puerto Rico. The local team procures there. Usually it's older grafts. The liver arrives in my center 7 hours and something, usually 7, 8 hours. So I have, in general, my recipient ready. Liver hanging by the hepatic veins, portal vein, and artery. So we just, another one, that case, for example, these older grafts, they don't take much ischemic time. They don't regenerate well. The 95-year-old donor that I did was in the Northeast, was in New York, the donor. So I also had everything ready and everything else. So there's even a case that we can delay the procurement if it's close by, hold the cross clamp a little bit so we can move our recipient after waiting, looking biopsy is a marginal graft, but we decide, oh, looks good. hold a little bit, let's bring the patient to the ward to make sure that we cut the ischemic time. But starting the case early is always an option. And mainly if you have your team procuring someone that you trust, I think that's a big advantage, and you should do that.
Hello, André. Any final question?
Yeah. If we have time, just one more question to Thiago. And Thiago, I want to know if you prepare the artery before taking down the portal vein, or you prepare the artery during the time of doing the anastomosis. And if in any case do you do simultaneous reperfusion, portal and arterial reperfusion at the same time?
Good question. I don't. I do the artery after reperfusion. So I dissect the artery after reperfusion. Again, I want to put that liver in. So if you have time waiting for the graft, probably is a good moment to do it. You're gonna find some varices, something still like the portal hypertension, but it's feasible. But in general, I reperfuse and then I go for the artery. The other question was, what was the other question there? Sorry.
The other question was if you do in some cases simultaneous reperfusion.
Oh.
Portal and arterial reperfusion at the same time.
Yeah, I don't say that I never done. I trained in Brazil under Professor Mies and was always simultaneous reperfusion. Here, I do portal. I did for some DCDs, the simultaneous, but I didn't see much value on that. So now all the DCDs case, we're doing this abdominal NRP. That for who's not familiar, we go, once the DCD expires, we wait the time, we open the patient, cannulate the aorta and vena cava, and put this donor on ECMO. So for 2 to 4 hours, we keep, there's clamps, the chest is dead, the legs are dead, everything clamped, and just the abdominal part is circulating blood. And we assessing the graft, the DCD graft. So we're pretty much making a DCD to become a regular donor. So all my DCDs I try to do with NRP. We start this year the program, and so far very good outcomes, even letting us to extend more the ischemic times that we accept. For this reason, I don't think it's necessary the simultaneous revascularization. I know some groups are doing for DCDs mainly here in the United States, but I'm not. I'm doing the standard, portal and then artery afterwards.
Okay, thank you, Thiago.
Marcelo, any final question?
No, I just make a comment that we agree with Thiago and Gondolesi that we don't need to do a portocaval shunt in every case. And even in fulminant case, if the patient is stable and the small patient, very easy surgery, we don't do a portocaval shunt. In very selective case, we do. And I would like to thank you, João, to invite me again, and congratulations, Gondolesi and André, and congratulations, Thiago, for the amazing results. I would like to go to know your group. Thank you, Thiago.
Anytime. It would be a pleasure to get people here.
So unfortunately, I'll have to finish the presentation. So I'd like to thank everybody, not just the people who have attended this presentation, but especially Professor Thiago Beduschi for this very surgical presentation. I'm very sure that you please very much the surgeons, because it's something that you do all the time, as most of the people who are here, and you see how you presented, you think and you imagine Maybe next time I will do this or this tip, just as you show on the left side. They're very interesting. And so I'd like to thank you as well. I'd like to thank you to Professor Gabriel Gondolesi, who also performs very fine job in Argentina. Dr. André Watanabe, who's becoming one of the top hepatic transplants in Brazil, who's performing among 100 cases a year. And my friend Marcelo Bruno, my pleasure to have you here again this year. And you're probably, you're going to be in the next one too.
Thank you. Thank you.
So thank you, everybody. So we're going to be finishing this presentation of the HPB 23. Thank you very much indeed for everybody. Thank you.
Thank you all.
Thank you.
Thank you all. Bye.
Thank you, João. Bye-bye.
Thank you. Good evening.